Please go ahead. So Prakash Rao presentation, who is, as you all know, that the founder of the IJCTO club. So I'm very happy and honored to present to you the CTO Legion Assessment Predictors of CTO Success. Dr. Prakash. Yep.
Good afternoon. Yes, there will be some overlap of the information in the lectures because the CTO PCI basics contain many overlaps. First of most important thing is how you read the angiogram, how many times you read the angiogram yourself. Maybe the interpersonal assessment and intrapersonal same doctor assessing different times. Yes, your decision will change. The collaterals you choose will change. This happens in real practice. So that's why read frame by frame, different angles. Take rotational angio if needed. Yes, there will be additional radiation risk, but in a difficult case, you have to do rotational angio. And always look for the neo channel. When you find it's a good sign that the chance of success are more. And like I see the RCA in a lateral view, mid-RCA lesions, and practically more useful, you find the channel in that particular view. The calcification and the plain cine is always not a good sign. The crossing of the devices, the antegrade, retrograde is always a problem. And so this is a very familiar picture. You see the stump tapered or flush occlusion, functional occlusion or total, and branch at the site of the lesion. I think most of you are familiar with this. So as Dr. Rajesh told, the CT, in a complex, I use a retry lesion. Mostly I use the CT to study, and a long lesion. There's two situations I take the help of the CT, and I usually give a gap of minimum 2 to 3 weeks for the contrast effects to go. Maybe some radiation control should be there. That's why what you see is the length of the lesion, the tortuosity, the calcification, and practically collaterals. I did not find much use in the CT angio studying rather than the conventional angiogram. So you can see here the lesion is absolutely not seen in the angiogram, where you can have, like what he said, is the co-registration. If it is there, very useful nowadays to enter a true lumen or from the fast lumen to true lumen. Like here, the distal occlusion, long segment calcium in the distal occlusion. So, can I play it again? So even distal occlusion, the CT shows a long segment occlusion with calcium. It's a very unfavorable sign. That's why we did not keep it in the live workshop, this particular case, because calcification always enemy of cardiology, in particular CTO, PCI, and even stent expansion also not good. Can you play it, somebody? So age of the lesion. Age of the lesion, yes, the more prolonged the CTO remains, the difficulties will be there. But more than that, the anatomy is more important. In a tapered occlusion like this, 10 years old occlusion post CABG is open because if the anatomy is feasible with a tapered and short segment, age may not be that important. So always I said the lesion assessment by simultaneous injections. What you see, the donor artery injection and the, can I replay this one? So what you assess here is the segment of the occlusion. No, the simultaneous injections useful to see the segment of the injection, segment of the lesion, the collaterals, the distal vessels. These are very important. If you got a very good distal vessel, and the collaterals are reasonable. Always, whichever approach you want to start and change to a hybrid approach, that is the advantage. So, lesion assessment is very important by the control simultaneous injection. So, here a tapering tape. We felt a tapering stump always good, not always. You see the calcium down. So ultimately you will face problem in crossing the wire, you can enter the false lumen, and the device carrying will be very difficult in this type of lesion. Stent expansion will not be good. So ultimate outcomes may not be good, even it is a tapered stump. So then you see alignment, proximal and distal cap alignment. Can you play it? So this is the alignment. You see the antegrade wire and the retrograde vessel absolutely in different plane. Here a CT may help you, and there is unless you know about this in a rotational angio, there is always risk of entering the subintimal plane, or even the perforation risk is there. So always you should assess. Now sometimes, can you play it? The proximal, the long occlusion in this case, but what we opened a bad diffusely disease with multiple tandem lesions. We thought it's a very long segment occlusion, difficult to open, but the proximal segment is a very soft occlusion. That's why you could open the vessel. So it may be a long segment, but the softer plaque, if it is crossed the CQO. Like visible distal vessel by retrograde is a good sign always, and you can manipulate the wire in your known fashion, and mostly with your experience you can enter, re-enter, and do, unless you put this a large hematoma, mostly you will have success. But here no visible distal vessel. So all rat-tail signs are, rat-tail sign is good sign, but not all. In this absolutely no distal vessel, either retrograde or antegrade, is a bad sign that you likely to fail. These type of lesions better not to attempt. And bridging collaterals, as you know, bridging collaterals previously we used to think, but nowadays with bridging collaterals with the Gaia wire family and all, and retrograde wiring and techniques, we can easily do these segments of CTOs. But always take care that if there is no retrograde vessel in a bridging collateral, very important, if you close a large bridging collateral during the procedure, there is staining hematoma, and you may lose the distal vessel. This is one risk always you should assess when you are doing only with bridging vessels. The side branch. A side branch occlusion at the stump. It is very useful to put a IVUS into it and see the proximal cap, but is always a bad sign for the success outcome. So there is a small stump here with a side branch CTO, and it's one way it is good that you can have a IVUS guided approach with the stump proximal cap puncture. The other way around, overall success rate comes down if you have a side branch. So you go for some other methodology like IVUS puncture or a retrograde approach or a anchoring balloon. So side branch at the CTO stump is important. But side branch 2 mm away from the occlusion, very poor predictor of success. It will always slip into the side branch. So a crusade catheter can be used in this type of lesions to enter the 2 lumen. And the side branch after occlusion, we have seen this observation. You can take help of the side branch like LED diagonal, one more diagonal at the distal to that. Here you can see this. We entered the distal diagonal, then we have done the plaque modification. Can you play the first one? So you can use the plaque modification. No, you can see the plaque modification you can do and enter the 2 lumen here. So this way the side branch at the distal occlusion is very useful. And flush occlusion, these are the most difficult cases for any senior operator also, unless you do retrograde wiring and a snaring. There's only technique what you favorable. Otherwise, the ostial occlusions of the RCA, just stump occlusions, and CT angio may guide you to locate the ostium, but it's very difficult cases. So like LED ostial occlusion, ostial occlusions, one danger of the LED ostial occlusions is mostly you have to attempt a retrograde procedures in these cases, and then there's a chance of ostial and left main stenting. You always take a chance in these cases. You have to cover sometimes the left main also in this case at the end. That you should remember. And dissection and protection of the circumflex is very important. So some type of cases you see long clear channel, we cross it with the wire, we have done everything, but balloon crossable not possible. So non-dilatable lesions, so even tornus, everything, nothing is able to pass. We have to do rota or a laser this thing, but unless you pass a wire, it is very difficult. So this type of things, if you study with the prior CT, it may guide you that how difficult it is. So this is the difficulty in pre-procedure CT may guide you that this is a difficult case and you have to prepare for maybe a laser wire can be passed, and nowadays the atherectomy can be done. So most lastly is the ISR CTO. One advantage of the ISR CTO is the stent margins always gives you some idea. So see the rotational angio, see that the wire is in the middle of the and lumen of the stent and not crossing sub. It should not go under the stats, and it's one way advantages in ISR CTO. So stent margins guides wiring within the lumen. Thank you.
Thank you very much, Dr. Rao, and probably a very much insightful presentation for how we assess and classify the complexity of the CTO. So thank you very much. We go on to the last presentation in this session. Yep, please.